Okay, here we go, our very last video for chapter 20, working through some of the cardiac physiology and how feedback loops work, how the heart regulates blood pressure, things like that. Starting off with some definitions. Mean arterial pressure, the blood pressure within the arteries, and then the mean, that mathematical thing, sort of like an average, right? Here is the equation that you need to know. Peripheral resistance is the total resistance against which blood must be pumped. So imagine this, you have a tiny hose that's 2 feet long, like a snorkel, and you got to blow the water out of your snorkel. Easy. But what if your snorkel were 15 feet long, you had that whole column of water above you? Would it be much more difficult to push it out? Yeah, sort of in the same way. Although there is some gravity, there's a lot of friction with the blood vessels, and our blood is just thick enough that it's a bit harder to push through than water would be. And so that peripheral resistance is all of those things, sort of that head pressure you might think of, working against gravity, and then the peripheral friction that we see. Cardiac output times peripheral resistance is mean arterial pressure. Okay, well, what's cardiac output then? Well, it's the amount of blood pumped by the heart every minute. The stroke volume times heart rate gives us cardiac output. Well, you know what heart rate is. How many times does the heart beat per minute? 60, 70, 80? Stroke volume means the amount of blood squirted out each contraction phase, each stroke, each ejection period, right? And that's measured in milliliters. So let's say, I think the academic textbook clinical average is 70. 70, let's get a calculator out here to calculate it. Let's say I have 70 milliliters of blood ejected every second. I have a nice low heart rate of 60 beats per minute. Look at that. That's 4,200 milliliters per minute. And so all I have to do is divide that, move my decimal point here, 4.2 liters per minute. That's pretty impressive. How many minutes are there in an hour? 60. Well, that's 252 liters an hour. Now we're talking about a big fish tank full of blood. And then, of course, there's 24 hours in a day. And so your heart actually pumps something like 6,000 liters a day, enough to fill a small swimming pool. Oh, that's a really disgusting visual image. Anyway, that's what we're talking about, cardiac output. And this is a good clinical measurement of someone's cardiac health, and one of many metrics that a cardiologist might use when they're trying to measure the progress or difficulty, dysfunction of their patients. Oh, love these flowcharts. Aren't they beautiful? I'm not going to walk you through this. You should spend some time looking at these flowcharts. Honestly, you should be able to describe all of this stuff. You should be able to understand all of the words on this chart by this point in your career. And this is another excellent learning activity. Spend some time looking through and thinking through how that works. And then as quickly as you can, put this information onto flashcards and start sorting it out on the table, because that's when you're really going to start to make the connections and to see what you know and what you don't. As I mentioned earlier in one of the videos, the heart is capable of generating not only its own rhythm, but of keeping up with supply and demand. Part of that is this so-called intrinsic regulation. You may know this word means it's built in. It doesn't depend on outside forces. And so there are some more beautiful definitions in physiological phenomena we need to understand. Preload and afterload. Preload is really the amount of stretch on the ventricular walls. The greater the stretch, the greater the force of contraction. So think about this. You fill up a balloon and you're going to squirt it out and squirt your naughty kid who just dumped a bucket onto you. As you fill that water balloon, the more water you put in, the more the balloon is stretched, and therefore the more forceful the squirt will be. That's really what we're talking about here. If we look at this visual, we can see that during atrial systole, the ventricle is being filled actively, right? It's being stretched, it's sort of topped off, and that preload is going to determine the force of the ventricular systole. The greater the stretch, the greater the force of contraction. Afterload is, of course, after ventricular systole. This really refers to the blood pressure in the aorta. Pressure that the contracting ventricle must overcome to move blood into the aorta. So if we go back to our award-winning infographic, we would be looking at this point right here when the aortic valve opens. During isovolumetric contraction, the blood pressure is rising and rising and rising until the blood pressure in the left ventricle is greater than the blood pressure in the aorta. That's when the aortic valve opens, and that's when blood flows out of the ventricle, right? And this is our period of ejection. Now here's the deal. If your patient has very high blood pressure, what does that mean for the period of isovolumetric contraction? Blood pressure is rising and rising and rising and rising, and it has to rise some more to overcome that very high blood pressure in the aorta. So, going back to this definition, afterload. Patients with hypertension have a much higher afterload, and we can see that the heart is going to have to increase its force of contraction to overcome that afterload. It's part of the whole syndrome. That's not quite the right word I'm looking for, but it's part of the whole situation around high blood pressure. Not only is high blood pressure bad for our health because it could give us a stroke or damage our blood vessels like in our retina or peripheral vascular issue, but high blood pressure is bad for our heart because it increases the afterload. And therefore, the heart has to pump with more force every time in order to get the job done. I talked about this idea in a previous video. You might go back to, I want to say it's video C, or maybe D, there are so many, where we were looking at the pacemaker potential. But you might remember that the parasympathetic division is sometimes called rest and digest, and that the sympathetic division is sometimes called fight or flight. So if I'm about to go on stage and give a speech to a whole bunch of people, then I may go into a sympathetic state. And we can see here, cardiac nerves innervate the SA and AV nodes, also the coronary vessels, and there are some connections right into the myocardium itself. So we get this adrenaline rush, and then we see increased heart rate and increased cardiac output. So not only do the SA node and AV nodes begin to depolarize more quickly, increasing the heart rate, but the effects of epinephrine and norepinephrine increase that rate of contraction, that force of contraction. We call that an inotropic effect, a positive inotropic effect. In the exact opposite way, if I'm meditating or I'm in a very quiet and comfortable and familiar place, I don't want to be panicked. And so I even at an unconscious level go into a parasympathetic state. Vagus, it's all about the vagus. The vagus is our most important cranial nerve 10, and it is the most important parasympathetic nerve. And much of our parasympathetic outflow from our central nervous system to our organs comes out through the vagus nerve. So it relates to sexual arousal, and it relates to speeding up digestion and slowing down the heart rate. How does it do that? Well, look at this. It uses acetylcholine onto a muscarinic receptor, as a matter of fact, found within the SA node and AV node, and it has exactly the opposite effect of epinephrine and norepinephrine. It hyperpolarizes the heart. So if you look back at that SA node potential pacemaker potential slide, you'll see what I mean. The slope of the pacemaker potential goes down because of this inhibitory neuropeptide. Last but not least, hormones. So not only do we have direct neurological stimulation during a panic attack or an emergency situation, but the adrenal medulla also pumps out epinephrine and norepinephrine into the bloodstream. So these are tricky ones. They're not only neurotransmitters, but they are endocrine hormones in their own right by the fact that they're flowing through the bloodstream to affect tissues chemically, through the cardiovascular system. You might suspect that these also have a positive inotropic and positive chronotropic. Chronos is time, and so chronotropic means it speeds up the heart. Other effects on the heart can be seen here, and you should definitely pause the video and spend some time looking through these. This is flashcard material. This is research material. Here's a great visual helping us to understand what I was talking about before and these so-called baroreceptor and chemoreceptor reflexes. Baro means pressure, like barometric pressure. Chemo means chemicals. And so on the previous slide, it talked about the fact that our pH and our carbon dioxide levels can have an effect on heart rate. And so look at this. If the blood pressure changes, it is detected in the aorta by these baroreceptors, blood pressure detectors. When they reach a certain threshold, they fire a signal to the medulla oblongata, most inferior part of the brainstem, and really completely involuntary. So this happens even without us really having to think about it, and sometimes without us even being aware of it. If the blood pressure is too low, it's going to signal a sympathetic signal. Speed up the heart. Make the heart pump faster to increase blood flow and help to restore balance. If the blood pressure is too high, under normal circumstances, the medulla will just say, hey, slow down a little bit by sending a parasympathetic effect, inhibitory effect to slow down the heart, and to a lesser degree, decrease the amount of contraction or force of contraction. This pathway also shows us that a fight-or-flight response will send a signal to the adrenal gland. This is a neurological signal that arrives in almost no time at all, and then within a second or so, the adrenal medulla is pumping out the adrenaline-like hormones. Adrenaline isn't a chemical. It is epinephrine and norepinephrine. We used to think these were one chemical. We called it adrenaline, named for the adrenal gland. Now we know they're two different, although very similar chemicals, epinephrine and norepinephrine, which will flow through the coronary arteries to have a synergistic effect on the heart rate. These ones are really nice to help you understand how that feedback loop works. Not from a circular perspective, but sort of as it's related to time. What happens if blood pressure drops? What happens if blood pressure rises? So you can spend some time working these on your own, and be sure to watch this animation embedded within your PowerPoint. Very last slide here, ladies and gentlemen, a couple of diseases and disorders that you might want to look at. This is not a pathology class, and so I tend to reserve the pathology questions for extra credit on the exam. So if you spend some time learning about these conditions, you might earn a point or two on the upcoming lecture exam.